My name is Robert Riley, interventional cardiologist in Bellevue in the Seattle area, and I've been asked to present a few cases of AGENT. We've had AGENT for, a handful of months now, something like that. Done a lot of cases, and we just want to kind of go over what that looks like in contemporary practice. So the most important piece of AGENT is actually the vessel prep prior to utilizing your device. So if you don't have good vessel prep, AGENT really doesn't help you get where you need to go. Boston, a few friends have put together this basic kind of ISR algorithm to help get to that point of ensuring proper vessel prep in order to get yourself to where you're going to be able to utilize the device and get the kind of outcomes that we saw in a GIT1 trial. And it first starts off with defining why did your stent fail in the first place, right? We have contemporary stent failure rates of roughly 7% or so over a several year period. And so most of them shouldn't fail. But when they do fail, one has to figure out why it is. Because if you don't correct that, AGENT is not necessarily going to get you up in the line of keeping it that way. Intravascular imaging is a key piece of that because angiography doesn't necessarily tell you why the stent fails. So utilizing that intravascular imaging to tell you several different things. One, why did the stent fail? Is it because there wasn't good prep first? Do we need to modify exogenous things like calcium? Is it that there's neoatherosclerosis that's occurred? Could it be late stent thrombosis? Or could it be calcified neoatherosclerotic plaque? These are all very different mechanisms of failure and sometimes require different treatment strategies. It'll also tell you your diameter, right? So you've got to know what the diameter of your vessel is and your stent, so you know how to properly do vessel prep and how to size your engine appropriately. And then finally, this can tell you a length, right? So we have different lengths of those AGENT balloons. We want to be able to use the appropriate length that'll go with the ISL segment. And so that's where intravascular imaging is key and really a foundational principle of treating in-stent restenosis lesions, which is why you'll see it there as number one. Number two is in that prep piece. So as you all know, for those that treat in-stent restenosis, it can be a bit difficult because the neoatherosclerotic process is different than de novo lesions. And so your traditional NC, semi-confined lesions, things like that, A, they often will expand appropriately to get you that proper vessel prep. And B, they'll often slip because we'll often see your smooth edges because of the different type of neoatherosclerosis that you get in-stent, of course, de novo. That's where things like Wolverine and things like that can be really, really helpful because you can slowly expand that. The razor blade, biotones, whatever you want to call, will essentially shoulder into that. Then the balloon will slowly expand. You'll get that nice one-to-one and get that good vessel prep. You then want to reassess after your vessel prep. So whether you have to use the calcium solution, regular NC balloon, Wolverine, whatnot, you want to reassess and make sure a couple of things. One, you want to make sure that especially if you're treating at the edges of the old stent, you don't have any edge dissection. Because that's really important. Because that's one thing where AGENT can be contraindicated. We don't want you big edge dissections. The second is going to be plaque reduction. We want to make sure we have significant plaque reduction. So depending on whether you want to look at the trial data, et cetera, we roughly say you want at least 30% or less plaque at that point. It's often just a visual. We want to make sure there's a significant reduction compared to our initial IVUS ceramic. And then the third thing is, obviously, if there's calcium, we'll make sure you see those nice fractures. Again, we're often using our Wolverine in these situations, nice calcium fractures, so that we know we're going to get good expansion of the AGENT, good drug delivery into those crevices that we create inside the calci. Then we treat our lesion with the AGENT balloon, again, one-to-one size, somewhere around 60 to 120 seconds, depending on data that's continuing to come out. Longer may be a little bit better, but again, it's a little bit patient lesion specific. And then finally, the final angiographic assessment. It's very important. We do not IVUS after we do the AGENT. It's current best practice. There's maybe a worry that taking the IVUS catheter back through could disrupt some of the excipient with the drug on it, potentially make the device kind of work as well long term. So typically we IVUS after our vessel prep, before our AGENT delivery. After AGENT delivery, you really assess with angiography for the adequacy of the result. So this is just a couple of cases to sort of illustrate that point. You can see here, this is an older female, bad resting aging, this is stable coronary disease, anterior ischemia. It's not hard to see what the issue is, right? There's a proximal thin-stent restenotic lesion that appears very focal. This is a bit difficult to get things across. So small balloons to facilitate our IVUS. We don't need to go one-to-one here. We just want to get our X down and see what the problem is. We then flip through and our IVUS shows us that our stent's actually reasonably well expanded, but it's really just a soft neoatherosclerotic plaque here. So this is something where we don't necessarily need calcium modification per se. This is where we can take our one-to-one size Wolverine balloon, get nice expansion. We don't have to worry about slippage, anything like that. expands well, looks good. We run our IVUS back through and you can see there's a significant reduction in neoatherosclerotic plaque, less than 10% in this case. We also want to check our MSA, right? We're shooting for that at least 5 to 5.5, or in our smaller vessels, at least 90% or more of our target vessel, target reference vessel. And in this case, we've got an MSA above 5.5, significant plaque reduction. Now we're ready for our agent. We move on. We give ourselves, again, somewhere between 16 and 120 seconds. Patient does well in this situation. In this case, we actually had an FFR wire already down, so this is something to check that from time to time, especially early on, where some people are saying, oh, gosh, I'm just so used to using stents. Is this okay? Sometimes having that wire down just to check yourself can be really nice. This is the final angiographic result. So we have a very good physiologic result. We have an excellent IVUS result. We have excellent angiographic result. This is our second case. This is somebody, again, with a lot of symptoms despite multiple drugs. So we'd bring him in. And what you see here is just this diffuse nature disease. There's nothing that really jumps off the page to you where you say, oh, it's definitively that, like we did in our first case. This is more subtle, but the patient has a lot of symptoms. They're on drugs. So there's something going on. This is, again, where our physiology can really be key. This is where we take our comet wire down and we can see clearly that it's a very diffuse nature of ISR there. Now, in the past, a lot of people have said, oh, well, that's diffuse disease, so that's better treated with medicines, but patients are not multiple medicines. Patients fail that aspect, so you need to do something. Physiology tells us that fixing this will have a positive or for symptom stated from a long-term target sort of vascularization rate standpoint. So in this case, we bring our IVUS down, and it shows us exactly why our FFR is positive. It shows us that A, the stents are undeployed, so they're not well opposed, they're not well expanded. And B, there's diffuse, soft neoatherosclerosis. So again, we don't necessarily need a calcium modification per se. We just need to be able to get in good vessel prep agents like our Wolverine. Now, the one thing I will tell you is in this case, IVUS was a bit difficult to get down. And what does that tell you? That doesn't tell you that the IVUS is the problem. It tells you that there's a lot of diffuse disease from these undeployed stents. One thing about AGENT is what you don't want to do is take it in, not be able to deliver it, and then have to take it back out and then take it back in again. That's one thing we try to avoid. It's hard not to touch it when it comes back out that second time, exposing it to blood multiple times. Does this take away the drug's efficacy? Possibly. So anytime you get an indicator with your IVUS that there's going to be a issue, you'd want to preload with the galvanic extension. But one of the things I really like to do is unsheath my instruments, like my Wolverines, my agents and things like that, because again, I want to make sure it's going to get there the first time. So in this case, what I did was I took a semi-compliant balloon down to the area where I wanted to treat, blew it up, anchored it, took the guide extension over that. Then I took my Wolverines through that, simply unsheathed those as they came back. So distally, I knew it was a 3.0. So I take my guide extension all the way down. I unsheath my 3.0 guide Wolverine there, and then take my larger Wolverines there more proximally as I back the guide extension back. And then I take my IVUS back in, showed we have excellent SOS expansion, excellent reduction in the neoatherosclerotic process. And now we're ready for AGENT. Now, in this case, this is one where we had to use 2 drug-coated balloons, right? Because we have very different sizes and long diffuse disease. And if we choose to only choose just the proximal or the distal, we really haven't done anything, right? Because we've disrupted the intima all the way down these stents. So we really need to get drug there. And this is where it's really important. You do not want 40, 50, 60 millimeters of double layer stent raise. This is a young person. It's not acceptable. That's where the 2 agents can really be helpful, because treating the disease, right? We've prepped it with our Wolverines. Now we get drug there and significantly reduce our risk of those stents failing again in future. So 3.0, 830 agent distally, 3.530 agent proximate to the mid vessa. Then we get this angiographic.
Okay, so case number 3. This was actually somebody, so the case 1 and 2 were stable coronary disease, right? Your person who comes in electively, they're having symptoms, we got to figure out what's going on, and we got to treat them. This is somebody who came in with an acute coronary syndrome. So as you can see here, 78-year-old gentleman, prior TAVR, known several layers of stent in the left main into circumflex, who comes in with an in-stent. And you can see the angiogram here shows that there's a really tight lesion in that double layer of stent there in the left main going into circ. So this was actually done by a partner who stopped and said, I don't really know what to do here. What should we do? I don't know what I was doing, but the next day I was there. So this is when we sort of evaluated this, and I said, this might be a really nice agent case. So what we did was we got our guide in place. We ran our IVUS down prior to anything else. And what it showed actually is that the stents actually weren't that terribly expanded, but see here, there's a big thrombus area there. And that's what's causing the in-STEMI here. This is, again, a really nice case for a Wolverine, right? Because we do not want slippage from an NC. This is where our Wolverine's gonna catch, go into that thrombus, expand, really push it to the edges of those stents. As you can see here, really nicely done here. And again, this is why this is mission critical in this, because slippage in and out, you don't want thrombus to go proximal or distal in this case. We repeat our IVUS run through there, significant reduction in the thrombus burden. MSA is huge. Remember, this is a left main, so it's important that MSA is predictive, very much so, as opposed to other vessels for target vessel failure in the future. Now it's time for agent. We've got our 4.0 agent there. We leave it up for 120 seconds, and we have an excellent angiographic result. In this case, roughly took, probably 20, 25 minutes. So, case number 4, and this is a little bit of a different case here. So we have lots of cases, but this, we wanted to try and do some educational ones. This was a patient who was very symptomatic on multiple drugs, known inferior ischemia, clearly because the RCA doesn't look so hot here. We've got an old stent, really tight lesion, what's going on? This was, again, a partner who had referred this to me, and this was gonna be an agent case. It was like, yeah, it was a great agent case. We'll just keep going. So we get our pre-dil balloon in there. We knew what the stent size was. We get our Wolverine in there, get it all expanded, and then we run our IVUS through. But what's really interesting here is there's something funky about the IVUS. Right there, we're scrolling through, and it doesn't look right. The nice little halo of the stent, it looks funky at about 3 o'clock. So what I did was then I scrolled through, and there's a big funkiness right there, as you can see the arrow. That's a disarticulation of a stent. That's not supposed to be there. That is a problem. So then I said, well, we magged up, and what you can see right here, nope, that doesn't work. What you can see right here is there's a big stent fracture. And we identified that on IVUS. So again, this goes back to the importance of intravascular imaging. IVUS showed us there was a problem. I didn't see it angiographically at first. I was just, doing my balloon, getting ready to do my agent, do my thing. But then IVUS showed us there was a problem, and sure enough, when we magged up and used our dry cine there, you can see there's a stent fracture there. That's maybe not the best agent case, right? Because we have a mechanical problem here. This is not just under-deployed stent, neoatherosclerosis, something like that. This is stent problem. This needs to be fixed with metal. So this is where we utilize the properties of a Megatron. So stiffer stent, stiffer at the edges, better radial strength, deploy a Megatron in that area to try and prevent a recurrence of that issue with the architecture of the stent there, and we get an excellent result. And that's the end of the slide. So that's 4 different scenarios, some areas where we see single layer failure in stable patient, double layer failure in a patient, acute coronary syndrome, and then an area where maybe agent is the best for ISR. And that's the most important piece is, what's really nice with Boston is a complete portfolio from vessel prep to in-stent restenosis to sometimes when metal is needed, being able to have those different options, whether it's Synergy, Megatron, and all those different things. So thank you guys.